Okay, hello everyone. So today I'll be explaining about the pulmonary diseases of vascular origin. So this one includes four huge topics. It's edema, embolism, pulmonary hypertension, and diffuse pulmonary hemorrhage syndrome. Now, edema, I have made a video already on this. Embolism will be made by another student, and I'll be covering the first two, which is the pulmonary hypertension and diffuse pulmonary hemorrhage syndrome. Now, you also have specific questions on edema and embolism. So, my suggestion to you guys is that for this specific question, mention briefly, not to a large extent, on edema and embolism, whereas you can explain in more detail regarding hypertension and the pulmonary hemorrhage syndrome. So I'll do the same right now. I'll just mention about hypertension, pulmonary hemorrhage syndrome. You can look at the other video for edema and the other video for embolism as well. All right, let's go. So, what's pulmonary hypertension? Well, essentially, there is hypertension in the pulmonary vasculature, right? So, if you can imagine, you have the right side of the heart and the left side of the heart. Connecting between the two is the pulmonary vasculature because the blood flows from the right side of the heart into the lungs, right? And then from the lungs, it goes into the left side of the heart. So well, in the most basic explanation, in the most basic sense, whenever there is some sort of a blockage or when there's some resistance in the left side of the heart, the resistance is transmitted backwards to the lung vasculature into the right side of the heart. Okay, so that's one of the main causes for pulmonary hypertension, that is hypertension within the vasculature of the pulmonary system. At the same time, you could also have other causes where the etiology of this pulmonary hypertension is within the lungs itself. There's some sort of a problem with the lungs, some sort of a problem with the vasculature of the lungs, and that results in pulmonary hypertension. Okay, so it could either be because of the heart or it could be because of the lungs itself. Um, it could also be because of some sort of a systemic vascular resistance. Essentially, when the left ventricle has to pump with a lot of force into the aorta, maybe because of aortic stenosis or anything for that matter. Maybe there's idiopathic systemic hypertension, right? So again, the pressure is transmitted backwards, right, from the left ventricle into the left atrium and then back into the pulmonary vasculature. And that's going to result in pulmonary hypertension. Okay, so that's just the gist of it. Now let's go more into the specifics and I'll explain in greater detail regarding each of these. So, pulmonary hypertension, the first thing is definition. Well, it's essentially when the mean pulmonary arterial pressure is more than 25 mmHg, millimeters mercury, at rest. The normal value is usually 10 to 15. So you're looking at the pulmonary artery, and that's like, I think you can use pulmonary wedge pressure, for example, to identify this. So when your mean pulmonary artery pressure is more than 25 mmHg at rest, that's when you can diagnose it as pulmonary hypertension. Now, in the most basic sense, the pulmonary hypertension can be caused because when there is a decrease in the cross-sectional area of the pulmonary vascular bed, right? So imagine the pulmonary vascular bed. It's you've got a combination of series and parallel vasculature. Like I think you remember from high school, you have series circuits, electric circuits, and parallel electric circuits, right? And you know that in series electric circuits, the resistance increases, whereas in parallel circuits, each of the parallel circuit has got equal resistance. Or it can actually decrease. So similarly over here, you have, if you look at the cross-sectional area of the pulmonary vascular bed, okay, when there's a decrease in the cross-sectional area, you're going to have smaller vasculature and there'll be increased resistance. Another important thing I would like to mention over here is if you think about it, let's say you have the pulmonary artery, okay, it divides into two main branches, right? And then that divides further and further. Now, if there is a block in the left division or the right division of the pulmonary artery, right? And if you look at the cross-sectional area, so let's say, for example, the left side is blocked, right? So only the right side is now able to transfer the blood from the right side of the heart into the pulmonary vasculature. So the cross-sectional area is essentially only half of what it used to be, right? More or less, like just for the sake of simplicity, I'm saying it's half. But let's say, for example, that the left and the right main branches of the pulmonary artery are fine, okay? And somewhere further along the left side, right, the left branch, somewhere deeper into the lungs, there is some sort of a block in one of the smaller vasculatures. Now, if you look at the cross-sectional area, okay, of the entire vasculature that is present before the block, you have so many vessels that are dividing, right? On the right, like the branches of the right side of the pulmonary artery, it's supplying blood properly. On the left side, for the most part, it's supplying blood properly, but maybe there's one of the vessels that is blocked, and whatever vasculature is there beyond the block is not getting filled with blood. So the cross-sectional area, if you look at it, it's quite good. Like there's a large amount of lungs that are still being supplied with blood. So this is a very important concept that you need to know. It's that the larger the vessel or the more primary the division, sorry, that is like from the pulmonary artery to the primary left side or the right side of the pulmonary artery. If they get blocked, then you have a cut of the blood supply to a very large extent. And the more deeper you go into the pulmonary vasculature or the more smaller vessels are involved, the rest of the lung is pretty much supplied with a large amount of vasculature at that point, right? So it's going to be better, it's going to be fine. And that's why pulmonary embolism in the pulmonary artery itself is very dangerous compared to, let's say, a small pulmonary embolism somewhere deep within the vasculature, because the rest of the lungs are still supplied with blood. Okay, so that's just a very important concept that you need to know. Now, Um, when there's a decrease in the cross-sectional area of the pulmonary vascular bed, or when there's an increased pulmonary vascular blood flow, okay, this specific point is very interesting, okay. And you might wonder, well, if there's increased pulmonary vascular blood flow, how is it going to be pulmonary hypertension? Well, because of two reasons. Number one is that you're going to have more hydrostatic pressure, right, within the vasculature because there's more blood flowing into the vasculature. So that's one of the main reasons why that hypertension develops. And the other could be that there can be some spasms or there can be a reflex contraction of the vasculature because the vasculature is essentially dilating all of a sudden because of the hypertension. So there'll be a reflex contraction, and that could again increase the pulmonary hypertension. Now, again, the causes of the decrease in cross-sectional area or the increase in pulmonary vasculature blood flow has got the various reasons for each one of these. So let's look more into it. So again, to sort of summarize, pulmonary hypertension can be predominantly or mainly caused by decrease in cross-sectional area or increase in pulmonary vascular blood flow. The three main variables that are involved in, let's say, regulating these 2 points is pulmonary vascular resistance. So, more the resistance, more will be the hypertension. Um, Greater cardiac output, again, that will result in increased pulmonary vascular blood flow and increased left atrial pressure, which will transfer the pressure backwards into the left atrium and then into the pulmonary vasculature, as I had mentioned before. Um, yeah, so those 3 points. Now, pulmonary hypertension is developed when one of these, okay, or more of, if you can include two or three variables as well, it elevates the pressure over 25 mmHg at rest. Again, we're looking at this pressure at the pulmonary artery, okay, and that too, it's the mean pulmonary arterial pressure. Please keep that in mind. Now, if you were to classify this, there are many different ways to classify. You mainly have the WHO classification. It could be either the heritable reasons or acquired diseases. It could be hypertension caused due to left-sided heart failure, due to lung diseases and hypoxia, or due to chronic thromboembolic pulmonary hypertension, or there's some unclear or multifactorial or idiopathic causes. Okay. Again, there's some heritable reasons or some acquired diseases such as HIV or congenital heart disease or connective tissue diseases. Maybe there could be some mitral stenosis, right? And as a result, there'll be increased pooling of blood within the left atrium itself, and the left atrium cannot pump the blood into the left ventricle, so the blood just begins to sort of settle down within the left atrium, and therefore there's increased pressure, and that gets transmitted through the pulmonary veins into the pulmonary vasculature, and from the pulmonary vasculature into the pulmonary artery to the right side of the heart. Lung diseases and hypoxia, for example, COPD, interstitial lung diseases, these basically, in the most, like, if I have to explain it in the most basic sense, it would be that there will be damage to the alveoli, to the septa, right? And that will damage the vasculature. If you're going to damage the vasculature, then there's going to be decreased cross-sectional area, right? Because now you have fewer vessels supplying to the lungs, and that will again cause pulmonary hypertension. Now, chronic thromboembolic, what it means is you have a thromboembolic situation, maybe because you have some coagulopathies, maybe there is, what do you call it? Deep vein thrombosis, right? DVT. Um, so in these situations, there can be thrombus that can be formed within the vasculature, and then once that gets broken off from from those veins, it travels through the veins into the right side of the heart, and from the right side of the heart into the pulmonary artery. And then the smaller it is, the more it can go deeper into the vasculature. And if it's a chronic situation, there is, you know, multiple clogging of vasculature, right? Multiple small vessels can get clogged, and eventually that will decrease the cross-sectional area to such an extent that you're going to have a visible pulmonary hypertension. And usually that's chronic, okay? You could also have acute, but acute thromboembolic pulmonary hypertension is a very acute situation. Okay, that's acute is mainly when you have a very huge emboli that blocks more or less the first or second division of the pulmonary arteries, and that severely reduces the cross-sectional area. Other than this, you have some unclear or multifactorial mechanisms. This is mainly related to some genetic situation, which I'll explain again. So this is the five main things that you have to remember. Other than this, you can also classify this as obstructive pulmonary, passive, and hyperkinetic. Obstructive is basically when you have some pulmonary embolism, or when you have emphysema. Emphysema is when you have decreased amount of septa because the septa are basically breaking down, right? Or it could also be hypoxic vasoconstriction. So hypoxic vasoconstriction means that when there is hypoxia, okay, when many different parts of the lungs are not being supplied with sufficient oxygen, what happens is the lungs has a reflex mechanism of cutting off the blood supply to those areas of the lungs which don't have enough oxygen supply. So by decreasing the blood supply to those oxygen deficient areas, you're going to redirect the blood to the oxygen rich areas of the lungs. Okay. In doing so, you're going to increase the hydrostatic pressure within those vasculature that are supplying the oxygen-rich areas. Plus, because you're also decreasing the cross-sectional area, you're going to have an increase in the pulmonary hypertension. So there are two things. Number one, increased hydrostatic pressure. Number two, decreased cross-sectional area. Those two factors together will cause an increase in the hydrostatic pressure of the pulmonary artery itself, and that will manifest as pulmonary hypertension. Okay. So that's why hypoxia can be a problem. Now, we also have passive pulmonary hypertension, which is basically increased left atrial pressure due to mitral stenosis, or it could be because of aortic stenosis, which will then eventually transmit the pressure back into the left atrium. Then you have hyperkinetic pulmonary hypertension. This is quite rare. How do I explain this? So essentially, the pulmonary vasculature is very distensible, right? And additional blood pressure, additional blood vessels can be recruited. Um, so ideally, this shouldn't be causing hypertension, but um, well, there can be certain situations where the blood flow is so high as a result of um, increased utilization of vasculature, right? So many vessels will become occupied with blood that there'll be increased blood flow, okay, and that can also cause the pulmonary hypertension. Again, this is a bit weird, but just know it, you know. That's the second method of classification. The third one is just acute or chronic. Acute could be because of pulmonary embolism. For example, the when the left or the right branch of the pulmonary artery gets blocked, or when the pulmonary artery, the main branch itself, gets blocked, or maybe when the first three or four divisions of either the left or the right or both divisions of pulmonary arteries get blocked. Of course, this can also result in pulmonary infarction. Infarction is basically when you have so much of ischemia that the tissue goes from an ischemic stage into death, like it's literally dead, right? That's infarction. Chronic is when you either have multiple small emboli that are being continuously deposited and broken down, or maybe there can be other reasons. Uh, for example, because of COPD, because of emphysema, etc. So one very important thing that you see in pulmonary hypertension, as opposed to systemic hypertension, right, is that in pulmonary hypertension, you have a very high chance of seeing the right ventricular hypertrophy because you have hypertension in the pulmonary artery, right? And the one that gets exposed to this high pressure, the first one that gets exposed is mainly the right ventricle, right? So there can be a hypertrophy. Hypertrophy is essentially a mechanism to get adjusted to the new like extreme pressure stimuli. Whereas in systemic hypertension, the systemic hypertension is going to get transmitted through the aorta into the left ventricle first, right? And that's why you're going to see left ventricular hypertrophy first. But of course, if it's chronic enough, then this hypertrophy, this pressure will get transmitted through the left ventricle to the left atrium, to the pulmonary vasculature, to the pulmonary arteries, and to the right ventricle as well. And that can lead to right ventricular hypertrophy. But again, this is in a chronic situation when it comes to systemic hypertension, whereas in pulmonary hypertension, this can occur quite quickly. Okay, right. So that's the division. I hope this has been understood. Next, we go for the pathogenesis. So the pulmonary hypertension can be either primary, like there could be a primary cause, such as um, congenital or acquired heart diseases, left to right. Oh my God, what did I do? Left to right shunts. It could be idiopathic, and or it could be secondary to other conditions. So it could be because some other conditions like COPD, interstitial lung diseases, autoimmune, obstructive sleep apnea, recurrent thromboembolism, and yeah, that's pretty much it. Okay. So the reason why this is primary is because it's primarily involving the pulmonary vasculature, right? Or it's primarily let's say it's going to cause it's going to have a direct effect on the pulmonary vasculature. So any of these heart diseases such as mitral stenosis can again transmit the blood pressure into the pulmonary vasculature. It's going to cause a problem. If you have a left to right shunt, the right side of the heart will have more blood to deal with. Okay. Um, and this is going to result in an increased pulmonary blood flow, and therefore you're going to have a right ventricular hypertrophy. Again, it has to bear the pressure, the hydrostatic pressure of the increased blood flow into the right side of the heart. Also, there's an increased oxygen demand, right? Because now the right ventricle has to pump more and more, so there's increased oxygen demand from the right ventricles. So this can cause right side heart failure and cor pulmonale. Um, and then you also have a right to left shunt eventually, right? So from left to right shunt, the blood pressure on the right side of the heart becomes sufficiently high enough to now cause a right to left shunt. And that's called Eisenmenger syndrome. I hope I haven't butchered the name, but yeah, you get the point. I'm gonna highlight this. And you have some idiopathic, right? So you exclude all other causes, and what you're left with is an unknown cause. This could be because of some genetic basis where you have an autosomal dominant trait. where you have an inactivating germline mutation in the gene that encodes BMPR2, that is bone morphogenic receptor 2. When there's an inactivation, okay, or when there's a mutation that results in an inactivation of this, what's going to happen is you're going to have an overproliferation of vascular smooth muscle cells. And remember, smooth muscle cells are surrounding the pulmonary vasculature. If they increase in size and if you have an increase in number, it's going to decrease the diameter. It's going to decrease the diameter of the vasculature, and that's going to cause occlusion. Not only vasculature thickening, but also occlusion. And again, that's going to cause pulmonary hypertension. And because this will also lead to dysfunction of endothelium, you're going to have a decrease in nitric oxide and prostacyclin synthesis, and you know that they are basically vasodilators. And you're going to have an increase in endothelin and thromboxane instead. Well, essentially, endothelin and thromboxane are usually produced in some quantities, and nitric oxide and prostacyclin usually balances the effect of endothelin and thromboxane. But of course, when you have a decrease in these two, the effect of these are going to increase, and that's going to cause vasoconstriction. Okay. Now, secondary to other conditions, COPD or interstitial lung disease. Well, I would argue that this could be primary. Um, but anyways, just learn these individual points like congenital acquired diseases, left right shunts, idiopathic, etc. Like learn all of these things, and you can put all of these points into these. Okay. So, for example, the BMPR2 gene related situation can come under this. When I'm going to talk about COPD and interstitial lung disease, you can put them under this point. When I spoke about the what do you call that? The mitral stenosis, you can talk about left side heart diseases. When I mentioned about congenital heart diseases, you can just mention it under this point. Okay. Right. So let's continue. Again, COPD or interstitial lung disease, as I mentioned earlier, is going to cause destruction of lung parenchyma and it's going to obliterate the alveolar capillaries, therefore decrease cross-sectional area and therefore increase resistance. Same thing goes with interstitial lung diseases. Okay. Also, another point that I mentioned earlier, when you have an improper diffusion of oxygen, okay, because of COPD or interstitial fibrosis, there's going to be a reflex vasoconstriction. And again, like I mentioned earlier, the blood flow is going to get redirected to oxygen-rich areas, right? So that's going to happen. Now, if this disease or if there is decreased oxygen supply to a large amount of lung tissue, or if it's diffuse everywhere, then large spaces of the lung gets deprived of this blood, and this can result in pulmonary hypertension. Okay. Then you have recurrent thromboembolism. Again, recurrent multiple thromboemboli, small ones, big ones, up to a point where the cross-sectional area decrease is significant enough to cause a significant pulmonary hypertension. Autoimmune diseases such as systemic sclerosis, again, sclerosis, hardening of the vessels, or fibrosis of the interstitium, which will again cause decrease in the ability of the vasculature to dilate, and also it can cause narrowing of the vasculature. Right. Now, obstructive sleep apnea. Okay, so here's the thing. With obstructive sleep apnea, essentially, like for example, let's say the tongue is blocking the nasopharyngeal and the oropharyngeal connections, right? Wait, sorry. Let's say it's blocking the oropharyngeal connection with the larynx, or let's say that there's a person is obese and therefore the organs are sort of pushed up, um, and as a result there's increased respiratory effort, right, due to airway obstruction. When this happens, when there's airway obstruction, you're going to have decreased oxygen flow into the lungs, and again, like I mentioned earlier, it's going to cause pulmonary hypertension. It could lead to pulmonary because obstructive sleep apnea is usually chronic unless treated, and especially with obesity, it's really chronic. Now, the clinical manifestations. Finally, we finished the hard part. We come to the easier one. Clinical manifestations. What do you have when you have pulmonary hypertension? Naturally, there's going to be dyspnea, right? Difficulty in breathing. And if there's not enough oxygen supply to the lungs, you're going to have fatigue because muscles aren't getting enough oxygen. Then, obviously, not enough oxygenation of the blood, cyanosis, and sometimes angina chest pain as well. Remember, angina chest pain, the pain radiates. Well, in heart attacks, it can radiate to the to the left arm. It could radiate backward as well to your trunk. Over here, the manifestation of a pulmonary embolism or a pulmonary hypertension can be very similar to that. And then you have morphology. So, uh, with morphology, just mention vessel problems, okay, and right ventricular hypertrophy. Okay, now with vessel problems, if you're looking at the pulmonary muscular and elastic arteries, okay, which are large vessels, the tunica media, okay, gets undergoes hypertrophy, and the intimal layer, okay, the innermost layer, um, will undergo hyperplasia. If you're going for the smaller vessels, arterioles and the small arteries, you're going to have medial hypertrophy and intimal fibrosis. Okay. And I think this has to do with the fact that the larger vasculature can has a better how do I say is much better in accommodating this increased pressure so they can undergo hyperplasia and hypertrophy rather than the arterioles and small arteries where the damage to the endothelium can be high enough to cause fibrosis. And I think it also has to do with the fact that there isn't enough cell signaling and organ and nutrients in order to cause this hyperplasia and hypertrophy. And of course, the arterioles and small arteries are very small, so having hyperplasia and tunica media hypertrophy to a large extent will actually occlude the vessels rather than actually helping. So fibrosis can narrow the lumen, but it will not necessarily block it completely, you know. But that's just a point that I would say is more of a reasoning. Now, you also have something known as a plexogenic pulmonary arteriopathy. It's very important. So, when you have obstruction of blood flow to the pulmonary arteries and arterioles, the compensation to this can be neovascularization. Okay, and neovascularization is essentially collateral channels originating from the intima. Okay, and through the vessel itself. So, through the wall of the vessel itself, you could have new vasculature. Okay, and it could also pass through the vasculature and form new vessels. Okay, and it will connect back to the same vessel, or it can connect to some other vessels. Essentially, there's a new network of vasculature that's developing within the wall of the artery and through the lungs itself. So this again could cause a decrease in the integrity of the vasculature because the walls are now having vasculate vessels, smaller vessels, and it can also increase the number of collateral channels. And in this way, sure, there could be a decrease in there could be an increase in the cross-sectional area, but again, you have increased blood flow into the pulmonary vasculature now, or maybe the same as well. And this could have some effects on the pulmonary artery itself. There could be increased pressure because of increased blood flow to the pulmonary artery. And of course, you have pulmonary artery atherosclerosis, right? Either due to inflammation of the inner walls of the pulmonary artery, or due to emboli, or it could be due to multiple other factors. Um, and in severe cases, you can have atheromatous deposits, okay, which is basically ultimately going to lead to this one. And then apart from vessel problems, you have the right ventricular hypertrophy that I mentioned earlier. Complications, well, ultimately cor pulmonale can lead to death. How does this occur? Well, you have the hypertension occurring. It can cause severe respiratory distress, cyanosis, and right ventricular hypertrophy. And then there could be enough, like there could be a lot of oxygen requirements by the ventricle, and when it gets decompensated, when it's not compensated, it can result in heart failure, but on the right side, so called pulmonary. Now, healing and prognosis, well, you just treat the underlying condition. And if carpulmonary develops and it's uncompensated, 80% of the patients die within 2 to 5 years. So that's got everything to do with pulmonary hypertension. Okay. Now let's go for the second one. So we have diffuse pulmonary hemorrhage syndrome. Basically, it's blood leakage from the pulmonary microcirculation into the alveolar space. Why could this happen? Mainly due to microvascular damage. This can actually be seen in pulmonary edema. If you guys have watched my video on on pulmonary edema, I stress on this a lot. So in a simple sense, the lung is basically filled with, it's made up of alveoli, right? And the alveolar walls is nothing but the septa, right? And if you look at the wall of the alveoli, which is nothing but the septa, you realize that on if this is the septa, okay, on this side, right, you have the alveolar space, and you have got the alveolar cells, okay, alveolar cells type 1 and type 2, pneumocytes type 1 and type 2, okay, and in between over here you have the septa itself, and within the septa you have connective tissue, and you have the pulmonary vasculature, okay, and on this side you could have again another alveolar space, okay. So um, within the septa, if let us say that the vasculature is going to get damaged, okay, or let us say that there's some sort of an inflammatory reaction, maybe there's a pneumonia, right? And as a result, this septa gets broken down by inflammation. So the septa just disintegrates. And now what do you have? You have either an occlusion of the vasculature, or you just have the vasculature open, right? And that's going to leak blood into the alveolar space. So this is not there anymore. It's going to disintegrate. And now the alveolar spaces are free, okay, and they're going to get filled with blood. So when there is a diffuse situation of this, okay, when this situation is diffuse in a large part of the lung or in a huge lobe, this is called it as a diffuse pulmonary hemorrhage syndrome, okay. It's a dramatic complication of some interstitial lung disorders. The three major causes: it could be an autoimmune disease, it could be a rare disorder such as idiopathic pulmonary hemosiderosis, or it could be polyangiitis with granulomatosis. It could also be because of, let's say, some severe infection, like maybe because of some parasite or because of some bacteria, or it could be because of some fungal infection. Now, in good pasture, what's happening is, again, you have the pulmonary alveoli, right? On this side and on this side. In between, you have the septa. And obviously, the septa on my palm, my right side of the palm is nothing but the basement membrane. My left palm is also the basement membrane again. On top of the basement membrane, you have the pneumocytes. Between the two basement membranes, you have the vasculature and the extracellular matrix and elastic tissue as well. And within this elastic tissue, you have collagen type 4. So when you have autoantibodies against this collagen type 4, these antibodies are going to bind to this collagen type 4. And obviously, the immune cells are going to recognize these antibodies. And you have the cytotoxic T cells, CD8 cells, you're going to have NK cells, you're going to have neutrophils, complement system, etc., which are going to attack or which are going to attack the collagen type 4, because the collagen type 4 is marked by these autoantibodies. And when they attack, they're going to destroy the basement membrane, the alveolar cells, and the pulmonary vasculature as well. And this can result in necrosis if it's diffuse enough, if it's wide enough. And this will result in hemorrhage, right? If the vasculature is going to leak blood into the alveolar space. And this will cause pneumonitis, interstitial pneumonitis, because it's the interstitial space that's going to get destroyed first, and it's going to be hemorrhagic. Therefore, hemorrhagic interstitial pneumonitis. Now, the same thing can happen to the renal glomeruli as well. The renal glomeruli contains collagen type 4. Autoantibodies bind to this. The complement system, such as C3b, then autoantibodies such as IgG, IgM also, but IgG is better. So these will bind to this collagen type 4. Immune cells will come and attack this. Maybe you could also have helper T cells, which will recognize these antibodies and which will signal to the other cells to come and destroy collagen type 4, right? So this is the process of Goodpasture syndrome. It's going to cause rapidly progressive glomerulonephritis and hemorrhagic interstitial pneumonitis. It affects mainly males. Macroscopically, you're going to have red-brown induration. Why? Blood is going to get into the alveolar spaces. Macrophages are going to try to destroy or trying to eat the damaged RBCs that have leaked into the alveolar spaces. As they eat the RBC remnants, they're also going to take in hemosiderin. And this, like macroscopically, when you have a diffuse situation of this, it's going to cause red brown consolidations, and it's going to be heavy because it's going to be filled with hemorrhagic fluid, right? Typically a transudate, but if it's, let's say, some sort of an inflammation, maybe because of bacteria or something, not necessarily in Goodpasture syndrome, it could result in an exudative hemorrhage. But over here is mostly going to be transudative. Yeah, and of course, necrosis can also be a breeding ground for bacteria, and that's going to convert transudate to exudative. Yeah, you're going to have microscopically hemosiderin-laden macrophages, and you can stain them with Prussian blue to demonstrate the accumulation of intracellular iron because iron is present in hemosiderin. Clinically, it's literally the same thing, dyspnea, and imagine if you have hemorrhage, you're going to probably have hemoptysis as well. um, so it's very like the clinical situation is pretty common, like dyspnea, fatigue, hemoptysis, gasping for air. What else? The position as well. They're probably going to lean forward, right, in order to be able to breathe better. Um, and if they lie down, there's going to be increased blood flow into the lungs, okay, because now the level is like the level of the vasculature is pretty much at the same uh, level, right? So they're going to have more dyspnea when they're sleeping. They're going to have more breathing difficulties when they're sleeping. And if you look at the X-ray, you're going to have consolidations, focal lung consolidations. It could also become diffuse if if the Goodpasture syndrome is diffuse enough. Okay. Yeah, and death is mainly by uremia, which is basically because of rapidly progressive glomerulonephritis. There's going to be increased uric acid within the blood, and that's very toxic to the body. You know that. Uh, and treatment is by intensive plasmapheresis. Plasmapheresis is basically where you flush out all the autoantibodies that are formed in the blood, and it's going to go through a machine, and then that's going to fresh blood is going to be given to your body again. Then you have idiopathic pulmonary hemosiderosis, right? Again, here you're going to have diffuse alveolar hemorrhage, more common in children as opposed to Goodpasture syndrome, more common in adult males in the 20s. And again, you have hemoptysis. You can also have anemia and diffuse pulmonary infiltration. Anemia because hemosiderosis is going to affect not only within the lungs, but it's going to have an effect systemically as well. And of course, polyangiitis with granulomatosis, it's a vasculitis. Okay. Um, so you're going to have a combination of necrotizing vasculitis and parenchymal necrotizing granulomatous inflammation. Basically, there's going to be necrosis. There's going to be granulomas within the vasculature, and within is going to then this granuloma is going to spread into the alveolar spaces as well. And C ANCAs are nothing but these antibodies, and they're going to be present. They're going to be positive. Okay, so yeah, that's pretty much it. It's a pretty big video, I think. It's going to be what 43 minutes long, but this is pretty much everything for pulmonary hypertension. Pulmonary hypertension is very, very important clinically. So I hope my explanation gives you a good idea of what everything pulmonary hypertension is all about. So to summarize, just mention definition, mention the causes, okay, and then go to the classification. And I would say mainly just focus on this. Just focus on the WHO classification. Everything else that I've mentioned with regards to pathogenesis, just put it into the WHO classification under this. Okay, and you're going to be fine. After that, go for clinical manifestation, which is very easy. Morphology, divide into vessel problem and hypertrophy. Within vessel problem, divide into large or medium-sized vessel and small-sized vessel and new vessels. Okay. And then, of course, this is also got to do something with the larger vessels. I should probably put this in here. But anyways, complications, coarse, severe respiratory distress. It could also cause ARDS, and decompensated corpus malaria. This is the final part, and that will lead to death. Healing and prognosis, just as soon as it's identified, appropriate treatment has to be given. You'll learn more about it in the future years. And for diffuse pulmonary hemorrhage, just remember if it's pulmonary hemorrhage, it has got to do something with vasculature. If it's going to do something with vasculature, and if you know it's going to be diffuse hemorrhage, it's going to do something with the wall of the blood vessels. If it's going to do something with the wall of the blood vessels, it means that the blood vessels are damaged, the walls are damaged. And if it's diffuse, then it's a large amount of damage, which probably means that the blood is going to leak out. If it's going to leak out, it's going to be a diffuse blood leakage. And that's also why it's called hemorrhage, right? And then you're going to identify that, okay, you have damage to the walls, you have diffuse blood leakage. What could be the causes? Good Pasteur syndrome. It could be because of idiopathic pulmonary hemosiderosis and a necrotizing vasculitis called polyangiitis with granulomatosis. Okay, cool. So that's about it. Thank you so much. And I hope uh, this information is sufficient enough for your exams. All the very best. Thank you. Stop sharing.